Okay, good evening, ladies and gentlemen. It is my great pleasure to start the second International Lipid Expert Panel webinar, which will be completely dedicated to familial hypercholesterolemia management. It is my great pleasure to be today evening with my great colleagues and friends, Professor Michal Vrablík from Prague, Czechia, Professor Pecin from Zagreb, from Croatia, and Professor Branislav Vohnout from Slovakia. So it is my great pleasure because these are real experts in the field of familial hypercholesterolemia. These are people that are very well experienced in managing of people with familial hypercholesterolemia. It is not a coincidence that the second webinar is completely dedicated to FH patients, because altogether we have about 32 million people worldwide with FH. The prevalence is about 1 per 215 to 1 per 313 based on the very recent data by Koch-Ray and the data from a Copenhagen study. What is more, we know it very well that the prevalence might be even 10 times more when we have patients with ischemic heart disease, 16 times more in patients with atherosclerotic cardiovascular disease, and even 20 times more or more prevalent in patients with premature ischemic heart disease. But altogether, we need to know, and we all know, we should aware about the fact that the problem is that for almost 90% of countries, we do not have a clear data on the prevalence of FH in those countries. So in this, during this webinar, we would like to talk about why we cannot diagnose, why we cannot find, why we cannot manage with patients with FH optimally, and what to do in order to solve and to all the challenges associated with the management with these very high risk patients, very high cardiovascular risk patients. Okay, in order to avoid the situation that we will have a delay with the questions after the presentations, at the very beginning we will start with 4 introduction presentations, and after that I do hope we will be able to answer all your questions on FH issues. And please send us as many questions as you have, taking into account your clinical practice. So we will start with the presentation by Professor Pecin, who will say a little bit more about his clinical experience, how to effectively diagnose patients with FH. So Ivan, it is a great pleasure that you are with us, and the floor is yours. Thank you very much.
Thank you very much, Professor Banach. Thank you very much, Maciej. Dear colleagues, ladies and gentlemen, it's a really privilege to be here with you on this webinar. Especially, I heard there is around 500 participants, that the patient organization are also there, and that my friends are also there, Brano and Michal. So I have quite a difficult task, because Maciej gave me the task to tell something what are the best experience on effective diagnosis of FH patients, and I'm still searching for them. And do we really need systemic solutions? And I'm still thinking about them. But we will start. I will start with one short video. So please look at this video. So this is completely normal person, as you can see here, and in 30 seconds, just remember, in 30 seconds, she will become a very famous person. So you need 30 seconds to recognize Mona Lisa. And why Mona Lisa? You will see. You know that the Mona Lisa is probably the most described or analyzed picture in the human history, I would like to say, because of the mysterious smile, look in the eyes. And there is a fact that she died when she was 37. The latest thing that I found is the thing that in her right eye there is some kind of code that leads to some kind of old boutique shop, antique shop in Paris that can decode the code of Mona Lisa, the Da Vinci Code, because she was painted by Da Vinci. And they say that we need a microscope to decode the code of Mona Lisa. But you will see that this is not the truth. So Leonardo da Vinci was a great scientist, and he was very, very also like the human body and anatomy. And look the way how she painted her. He painted xanthelasma. She died when she was 37. So, ladies and gentlemen, she was a patient with FH, with familial hypercholesterolemia. This is our medical theory, and actually it's published, I think, in one cardiology journal 12 years ago. You can search it on the internet. So what are the best experiences? Do we really need systemic solutions? Yes, because still we see this as pathological finding. This is not the aorta of old patient. This is the aorta of one complex heterozygous patient with FH aged 19. And one more thing I want to point on. Almost 100 years ago, Francis Gottfried Harbitz described the connection, he was a pathologist, in between, as you can see, sudden death and xanthomatosis. Unfortunately, in my country and in our surrounding countries, still pathologists are the first doctors that tend to make the diagnosis of severe atherosclerosis and FH. We have to change that. And thanks to Professor Steve Humphreys, he shared this slide. I want to point on that the FH is the disease when you have pathogenic variation and you are born with high cholesterol. As you can see here, on 1,000 patients, LDL cholesterol mean value is very, very high from early childhood. Without mutation, we are born with the LDL cholesterol around 1, and we are completely normally developed. So therefore, we shouldn't be afraid for the low cholesterol. And then something happens here. The cholesterol goes down. Why? Unfortunately, those patients are not diagnosed because we are not aware on time. And here they are diagnosed when they have first major cardiovascular event, and they are starting to be treated. How to be treated, you will hear from my colleagues. So no wonder if someone aged 75 or 80 got a myocardial infarction. But if you are an interventional cardiologist and you have a young patient, 40 or even 20 with myocardial infarction, you put a beautiful stent, you save life, but you have to ask why this patient has myocardial infarction or maybe stroke. This is still not the case. So FH is a lifelong exposure, and this is for sure disaster, a lifelong exposure of the LDL cholesterol. So the numbers, we have homozygous form, and for sure this is a rare case. But as Maciej said, the heterozygous form is not rare. It's 1 up to 250, but it acts as a rare disease because we do not think about the disease. We miss the patients, and this is very potentially lethal disease, and it is not lethal if we find the patient on time. So someone calculated that every single minute there are 250 children born worldwide. That means that every single minute there is one child born with FH. On European scale, this is one, as much as said, one country, like 2 million, for example, like my neighboring country, Slovenia, with patients with very, very high cardiovascular risk. And still, as much as said, more than 90% of patients are not diagnosed. As you can see here, the Netherlands, the Norway, the Czech Republic, the Spain, the UK, the Slovak Republic did some beautiful work. But this is upon numbers 1 up to 500. Croatia is about 1 to 2% of diagnosed patients, unfortunately, only. So from my point of view, the first manifestation is unfortunately early cardiovascular morbidity and mortality. And this disease also has some stigma of disease, as you can see here. This is my homozygous patient, and he was diagnosed when he was 3.5 years. Now in this picture, he has eruptive xanthomas, aged 5. After that, he was included to the LDL apheresis, and nowadays he has 19. And the dermatologist was the first physician that suspected that this is an FH, and he sent it to our lipid clinic. So this is the xanthoma. The other stigma is xanthelasma. It's not pathognomonic. That means that other diseases also can have these changes. But making the diagnosis in these 30 seconds is like making a pieces of puzzle. If you have arcus coronalis younger than 45, it is also can be pathognomonic for an FH. And this is my patient with tendon xanthomas, as you can see here. She unfortunately had a myocardial infarction, fortunately survived, and then she was recognized. So please, let someone take a stopwatch and from now to see how it's easy to make the diagnosis. So start. family history, early cardiovascular morbidity, mortality, high LDL cholesterol in family history, or children, as you can see, with high cholesterol, you have points. So those are the Dutch Lipid Clinic Network diagnostic criteria. Clinical history of an early premature cardiovascular disease. You have the stigma of disease, points. LDL cholesterol values, no matter what value you have, if you have the therapy, for example, if you use atorvastatin 20 milligram and you have LDL cholesterol 5, you have to multiply by 1.7 and you will get the LDL cholesterol. Full stop, stop the watch. We used 30 seconds and we made the diagnosis, yes or no FH. Or even more easier can be, you have a lipid tools, for example, online. You just click, 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 click. And yes, under 30 seconds, you can make the diagnosis, but you have to be aware about the disease. And there are some, I think, from my point of view, hot potatoes about an FH. This is the genetic testing and children. Genetic testing, because we cannot perform in Croatia genetic testing. I think my colleagues, my friends can in comments after my presentation and after their presentations comment more. So what about genetic testing? This is the gold standard for the diagnosis, and I stated if available, of the disorder and facilitated cascade screening. Pathogenic mutation, and those are the mutations known, there are some rare mutation, you know that, can be identified in 80% of definitive FH cases and 20 to 40% in those with the milder phenotype. So the Dutch Lipid Clinic Network criteria that I mentioned has a better sensitivity and specificity genetic testing. And the absence of no mutation does not exclude a diagnosis, because you sometimes have the overlap here. This is very famous, that slide. So you can have a clinical diagnosis without the mutation and you will for sure treat this patient. And you can have mutation without clinical diagnosis and you will observe and then also treat this patient. So if you only rely on cholesterol, as you can see here from this, and those are the references, you can miss every 5th patient. And there is a clearly connection in between the LDL variation and severity of mutation and severity of clinical picture. And what about children? So FH should be suspected in children and adolescents if they have LDL cholesterol higher than 4.9 millimoles per liter after the secondary causes are excluded. If one parent has FH, a child LDL cholesterol higher than 3.5 millimoles per liter, diagnosis is confirmed. But lipid levels can vary with age, as you can read here. So total cholesterol and LDL cholesterol discriminate better among children with and without FH at age 1 to 9. So European Atherosclerosis Society said the same thing as I mentioned here for the diagnosis of the adults and children. I like the data from Professor Wigman and his group. So this is a paper of Mickey Casters that published 6 years ago, comparison in between FH-affected children and their siblings, and they found that after the age of 7, there is a difference in carotid intima media thickness. So therefore, there is a rationale to screen at this age and start to treat at this age. They even put the results after 10 years of intervention with statin therapy, actually several months ago after 20 years, and they concluded that there is no significant changes in carotid intima media thickness production. So if you intervene and if you treat, no significant progression. So there was a beautiful online lecture last week, and you all know Professor Wigman, and I will quote him. So if you find a patient with an FH, you should intervene very early. And after that, you have to teach them 3 things. First, do not smoke. Second, take the therapy. And third, when you're crossing the street, look to the left and to the right, not to hit by car, because you will die. So if you intervene, your LDL cholesterol levels will be as the cholesterol levels and progression of the disease as the patients that don't have the disease, end of quote. So we can state that it's very easy to find a patient with FH. It's this goldfish, so it's a young. early cardiovascular disease, morbidity, mortality, high cholesterol levels, stigma of the disease. But for sure, this is not the case. So please, dear colleagues, cardiologists that you're listening, that you're dealing with the patient with myocardial infarction, please, on Monday, when you will be at doing your outpatients, in your waiting room, it will be for sure more than 12 patients after myocardial infarction. One of them, by chance, as Eurospire said, is potentially patient with FH. If it's older than 50, so every fifth younger than 50 should be FH. Please do not miss the patient. So the problem is worldwide, as Maciej says. This is the situation from one Greek report before PCSK9. Young patients with myocardial infarction, you clearly see here that they are not on proper statin dose. Ezetimibe is very low use. So only small percentage of them are at target value. I repeat, this is before PCSK9. My colleagues will show the newer results. But as a consequence of this, 40% of them, here is stated, after nine years, they will get the reinfarction. So they're still at very, very high cardiovascular risk. So what are the best experiences on effective diagnosis of FH patient? I think we have to be aware for the first thing, and we have to diagnose as soon as possible. And after that, we have to treat and go low as possible. Do we really need systemic solutions? Yes, but I think it should be personalized. What does it mean? It really differs from country to country. Genetic testing, as I mentioned, PCSK9 inhibition, yes or no? So is it available or not? But one thing should be systemic. We have to increase the awareness of the disease. So this is the first thing. I have to think it should be globally. At the beginning of the 16th century, if they were aware that the Mona Lisa had an FH, she will probably live much longer, become a granny or someone mother-in-law, but still with very mysterious smile and look in her eyes. Thank you very much for your attention, dear colleagues.
Thank you very much, Ivan, for a beautiful, very practical presentation. I would like to kindly ask everyone, all participants, in order to ask questions. We'll have a time for discussion, I hope, as long as possible after the presentations. Especially, there are many issues that needs to be discussed. First of all, why in Europe the mean age of diagnosis of patients with FH is usually about 50 years of age. Why in some of the cases we might do not have genetic diagnosis and phenotypic diagnosis, which cause that we recognize and diagnose patients with FH. So there are many different issues which are very important in order to take care of patients with FH optimally. But now I don't want to avoid the situation. I want to avoid the situation that Michal Vrablík, who is sitting on the luggages before the vacation, would like to say a little bit more about the management, so optimal management, especially, I am very invited taking into account the Czechia, because they are much more experienced and they have much more patients diagnosed with FH in comparison to Poland. So Michal is obviously much more experienced than me in the treating of patients with FH. So Michal, I am very glad you are with us and the floor is yours. Thank you very much.
Well, Maciej, dear colleagues and all the viewers and attendees, it's my great pleasure to be with you tonight, despite we can't see each other that well as during a face-to-face meeting. But I shall really say that thanks to Maciej and his fantastic effort, we have a possibility to meet and finally discuss issues around FH. And Maciej has asked me actually to tackle the topic of optimal management of severe hypercholesterolemia, including FH, not exclusively, and also to mention the very current issue of the pandemic situation that we are all facing. So I will try to do my best to answer the questions. So severe hypercholesterolemia, and maybe that we should really understand it doesn't have to be the autosomal dominant hypercholesterolemia that was very nicely elaborated in the talk of Ivan Pecin. So it doesn't really have to be the true FH, because we do have certain percentage of patients who have the phenotype of severe isolated hypercholesterolemia, and still they don't have the autosomal dominant inheritance mode, because they simply suffer from a very bad polygenic hypercholesterolemia. And in such a case, there may be common principles in terms of viewing and perceiving their lifelong increased risk. Though there's one principal difference between classical FH, autosomal dominant condition, and the polygenic one, and that's the onset of hypercholesterolemia. And Maciej has Ivan has very nicely shown us that in classical FH, LDL cholesterol rise very early in life. Basically, they are sky high from birth onwards. And therefore, these patients accumulate their LDL cholesterol burden very quickly. And we know that it's enough to accumulate 150 millimolar LDL cholesterol burden for, let's say, development of critical advanced atherosclerotic lesions. And we've already heard how important it is to identify the condition early enough so that we can flatten the curve that is otherwise very steep in heterozygous and even more so in homozygous FH individuals, as Ivan has very nicely shown. So I'm really eager to join the discussion and discuss the optimal diagnostic process for FH, because it's crucial, because if we don't simply understand and know where the people are, we cannot act as the guidelines are telling us. And we have multiple sets of guidelines now, some of them designed for FH, some of them tackling the entire cardiovascular risk, as we are going to be talking later a bit. We also do have the guidelines on identification of FH in childhood, which is crucial. And I'm really very glad the pivotal work of the Dutch group led by Professor Wiegmann has already been cited, because it's really very important. And basically, it means we are successful once we identify children affected with FH, because it allows us to really act on their risk through LDL cholesterol management lifelong. And also, it was very nicely demonstrated by British groups that we also can do reverse cascade screening, which means identification of a child leads to identification of all adult affected individuals, which is very, very powerful. So we do have the guidelines, and we also know where to lead our patients in terms of their goals. But I'm showing you some data, and Maciej has mentioned we in Czechia are very experienced treaters of FH. So I'm going to shoot ourselves into foot, because I'm going to share with you our recent data on how successful we really are, though the data were collected before PCSK9 inhibitors became available widely in our market. And I can show you that despite we try to establish a very sophisticated network of specialized FH centers in the country that are being gathered within the project called still MedPad Czech, we still are very little successful in attaining LDL targets in our FH individuals. And this is just a cross-sectional survey among our 9,000 identified FH individuals so far. So we selected some 1,800 of them. And you can see that the goal attainment in terms of LDL cholesterol values was as low as 15% only. It might be becoming better with availability of novel treatments, particularly PCSK9 inhibitors. But on the other hand, I must say that the penetration of the novel therapies is not great. And thanks to very stringent reimbursement criteria, we are struggling in Czechia as well as in other countries. So we are far from reaching the goals. And moreover, the goals are changing. I've shown you the older versions of FH-specific guidelines that requested attaining some LDL cholesterol goals for FH individuals who are asymptomatic, and also for those who are secondary prevention, so who are post-event. But we do have new guidelines published in September last year only. And these guidelines advocated much more prominent reduction of LDL cholesterol, in particular FH groups, like patients without other major risk factors and without a history of established atherosclerotic vascular event. They were classified in the context of FH as high risk. And we also do have the very high risk FH individuals who already suffered atherosclerotic vascular event. And in these people, the new guidelines actually recommend to achieve levels as low as 1.4 in the very high risk context or 1.8 in the high risk context. So basically, we are now obliged to bring our patients with FH even lower. And the question is whether we really can do that, whether we have therapies, because to achieve these targets, we must be aware that most of FH individuals would require decrease of LDL cholesterol in the magnitude of more than 80% from baseline. And basically, without a combination of statin, cholesterol absorption blocker, ezetimibe, and a PCSK9 inhibitor, it would rarely ever be possible to achieve these substantial LDL reductions. On the other hand, we shouldn't be skeptical because there are options. So we really can bring people with combining all these therapies to real levels, these targets. So I think that we should employ all the modalities we do have in the treatment to simply achieve the goals, because only after that we achieve maximum cardiovascular risk reduction in the FH population. Well, ladies and gentlemen, it's not only that we are troubled with guidelines that require very, very low levels of LDL cholesterol also in our FH population, it's also the other environment we're living in. And Maciej has asked me to tackle the issue of the pandemic situation and how it actually affects the management of FH, because we know all, it's a chronic condition, it's a lifelong condition, and it requires constant attention. It doesn't have to be constantly very frequent, but basically these patients need lifelong contact with healthcare, and we need to provide that even in situations that we've all lived through, that basically brought the lockdown measures and all the restrictions that we simply had to cope with. And definitely, as we come from all different regions and all different countries, I'm quite sure that we did have different experience and different methods how to deal with the totally novel situation. But we definitely all had to adjust to the new situation somehow. And as being aware of that, a group of ILEP experts have actually gathered and put down a short message, a short report on FH management during the pandemic situation that was published in Pharmacological Research. And it would be interesting to hear your opinions, because it may trigger a very welcome discussion and very welcome exchange of ideas, because of course we tried to summarize what the special pandemic situation really meant to us and how we dealt with it, what we considered as most important topics. But it will be very interesting, and maybe ILEP can provide a platform for the discussion, even during the webinars to come, to exchange ideas, because I believe that all of you viewing our today's program might have a very interesting idea, very interesting approach that might be copied and spread in other circumstances. However, we should be aware that the pandemic situation and the viral infection has put our patients into great danger, because FH is a high cardiovascular risk condition, and we understand that basically all high-risk individuals are prone to much more severe course of the SARS-CoV-2 infection. Therefore, it's crucial to ensure that FH individuals do have and access to healthcare. And I'd like to comment a little bit on the topic of telemedicine that, frankly speaking, I wasn't a great fan of before, but I needed to appreciate the advantages of these approaches during the lockdown measures. We also need to really think about safety of our healthcare facilities and proper instruction to our patients who shouldn't delay and avoid visiting healthcare facilities and seek medical attention when it's clearly needed. And unfortunately, now our health centers in Czechia are facing a number of cases that have basically delayed their visit to the healthcare facility. And unfortunately, we can see a lot of patients with heart attack that basically occurred some weeks or even months ago, and unfortunately was not properly treated. Unfortunately, also, our FH patients are very much prone to such a scenario, so they really need to be instructed properly whenever they get symptomatic, no matter what the general instruction, to avoid contact as much as possible, to keep distancing, not to visit healthcare facilities unless terribly needed. So our FH individual patients need to be consulted and instructed. Should they become symptomatic, they definitely need to seek medical attention immediately. What has really helped us a lot during the pandemic situation were the telemedical, I would say, approaches. And fortunately, we do have pretty developed system of e-prescription. Therefore, it was very easy to equip our patients with continuous medical supply of their drugs. And also we used a lot of home monitoring, not only the conventional blood pressure monitoring, but we also nowadays can use even the home ECG monitors that sometimes really help to consult our patients on phone. Moreover, we really needed to ensure our patients they are safe whenever they visit us in our offices. And of course, it required some refurbishing, it required some equipment. We had shortages of equipment, particularly in the beginning of the pandemic situation. But nowadays, I would say that we are very well ready, and our patients now have found their way back to our offices. They're not afraid anymore because they can see that we really do have very strict measures that are being followed and that prevent spreading the infection even within the facilities where we also do treat the COVID positive patients. So let me summarize a little bit the tips for management of severe hypercholesterolemia, of course, not only in the COVID era. So I'd like to emphasize that we are not dealing with temporary situation, and we need to tell our patients so, because sometimes they feel that, okay, after a certain period of time of using drugs, my cholesterol is down and I'm fine. We should insist on treatment goal attainment using all the modalities, including even LDL apheresis in certain situations. I think that particularly autosomal dominant conditions like FH are typical examples where screening in pedigrees helps tremendously and is perhaps the most effective way of identification of the affected individuals. And just as I highlighted during my talk, even during the pandemic situation, the FH population requires special attention and requires definitely to ensure that the continuity of care is maintained and that we keep the patients safe. And having said that, let me thank you for your attention with a picture of my home city, where perhaps some of you would recognize the beautiful Prague Castle, but most of you would not recognize this wonderful red roof here, which is a roof of the Department of Medicine where we practice. So thank you once more.
Thank you very much, Michal, for a beautiful presentation as always. My goodness, I don't know what to say and how to make a better presentation after Michal's one. It is almost impossible, you know. But on the other hand, I would like to kindly ask everyone again for please ask your questions about your everyday clinical practice. Please give the examples of your failures or maybe of successes, take into account the take caring of the patients with FH, because it is very important. We are here at your disposal. We would like to answer all your questions, because altogether the main aim of this webinar, the main aim of all those webinars of the International Lipid Expert Panel is to be much more effective in the therapy of the severe hypercholesterolemia. So I'm very glad to see the first questions, but it will be a good time in order to do it during the discussion, but please feel free in order to ask the next questions. Okay. Now, after such a great presentations by Ivan and Michal, I would like to say a little bit more about the reimbursement criteria in Europe, as well as the possible new data and new therapies which might be used in FH patients. So let's start with my presentation. Okay, as you know it very well, we have large differences taking into account the reimbursement criteria for PCSK9 inhibitors in many European countries. Here you have an example of the reimbursement criteria for PCSK9 inhibitors in Poland, which is in fact a drug program for FH patients, which is now performed and ongoing in 29 hospitals and centers. And altogether we started in fact in November 2018, and in practical way in March 2019 we were able to diagnose and we are able to include about 150 FH patients to this drug program. Altogether it is very limited, because as you might see it is based on the phenotypic diagnosis, because we know it very well that we do not need genetic diagnosis in order to start the therapy with PCSK9 inhibitors. But on the other hand, it is unfortunately with LDL cholesterol level over 160 for all those being on the maximally tolerated lipid lowering therapy with statins and ezetimibe for at least 6 months. So I believe it is a great limitations which caused by taking into account our experience, a year and a half experience, that we might altogether only include about less than 5% of all patients with FH, and still we have a number of patients being on the risk with LDL cholesterol level below 160, between 55 to 160, which are on the risk of recurrent cardiovascular events. In fact, we would love to have such a program which is in Germany, which is in the Netherlands, and as well as in our great colleagues and friends in Romania, in Professor Dan Gaita, Professor Daniel Ligezan, Professor Dragos Vineranu, and many others, our great friends from the International Lipid Expert Panel. Because as you might see, within this program, PCSK9 inhibitors are indicated in adults with primary hypercholesterolemia, familial heterozygous and non-familiar ones, or mixed dyslipidemia as a dietary adjunct. And it might be in the combination with statin, aronstatin, together with other lipid-lowering therapies in patients in whom it has not been possible to obtain target LDL cholesterol. But as you might see, there is no information about the other cardiovascular risk factors. There is no information about the levels of the LDL cholesterol which are necessary in order to include patients to this program. So I believe it is a very, very good program in order to use PCSK9 inhibitors effectively in those patients being at a very high and extremely high cardiovascular risk. But how the situation looks like in other countries. Here you have an example of the countries and the description of the programs in the European countries. As you might see, there are large differences between many countries in those countries, because in many countries taking into account the reimbursement programs for PCSK9 inhibitors, because they are completely different criteria for primary and secondary prevention. Usually, they are acute coronary syndrome patients and FH patients with additional risk factors. In only few countries, there is a mention that PCSK9 inhibitors might be used for statin-intolerant patients, and probably in only 2 countries, as far as I remember, in Slovenia and Bulgaria, there is a mention that it might be used also with patients with lipoprotein(a), with high levels of lipoprotein(a). So, as you might see, the differences are very large. But on the other hand, it's a good example in order to think about the kind of for those countries when, for example, in Poland, there is no drug program for acute coronary syndrome, to use the experience from other countries in order to be effective, in order to start such a program, a reimbursement program for PCSK9 inhibitors. What about the LDL cholesterol level? As I've mentioned to you, in Germany, for example, and Netherlands, there is no threshold for LDL cholesterol level, and there are different thresholds for primary and secondary prevention. Usually, obviously, it is not a surprise that for the primary prevention, the threshold level is a little bit higher, and for secondary prevention is lower, and usually, for most of the countries, this level is above 100 milligrams per deciliter. So I believe it is a little bit based on the data from Odyssey outcomes and Fourier data, when we know that for those patients with LDL cholesterol level over 100, we have a largest reduction of the cardiovascular outcomes and cardiovascular main endpoints. So altogether, I believe that we in all the countries should aim in order to have such a level of LDL cholesterol, obviously, because we know it very well that it might be based on the cost effectiveness analysis. It is only also restricted to the money in the different countries that might be simply used for such a drug program and such a reimbursement. Okay. Why it is important, why this threshold for LDL cholesterol is important? Because as you might see that we know very well, especially it is important for FH patients, that the baseline LDL cholesterol is critical in order to predict whether we will be able to achieve LDL threshold for the different cardiovascular risk patients. For example, if we have a very high risk patients for which we should be below 55, we know very well if we have a LDL cholesterol level over 140 as a baseline, and when we use statin therapy with the maximally tolerated doses, intensive statin therapy, we might reduce LDL cholesterol by about 50-55%. When we add ezetimibe, we might be additionally reduce LDL cholesterol level by about 15 to 20%. So altogether, for those patients with the baseline level of LDL cholesterol about 140, now we might be on the target. But as you know it very well, that for most patients with FH, it is these patients have a LDL cholesterol level, baseline LDL cholesterol level 200, 300, 400. So we know that for most of those patients, we will be not on the target using only statin and ezetimibe. So for most of the patients, we should have an opportunity to use PCSK9 inhibitors, because as you might see in the slide, it is possible to even reduce LDL cholesterol level below 55 if we start with LDL cholesterol level, baseline LDL cholesterol level about 300. Okay. What about the recent data and what we know about the recent data in FH patients? First of all, the main question was whether PCSK9 inhibitors are equally effective in patients in real life practice, in real life data. Here we have patients that were included to the Odyssey Prize data. It was an open label real life study that evaluated efficacy and safety of PCSK9 inhibitors in different groups of patients. They were very high risk patients and extremely high risk patients, because as you might see, there were patients with FH and different baseline level of LDL cholesterol over 130, 60 over 130. There were also patients with established coronary heart disease, as well as those which we now consider as those patients with extremely high risk, because they were patients with progressive cardiovascular disease and other concomitant disorders such as peripheral arterial disease. So in fact, in this study, we have all those patients that we usually might observe in everyday clinical practice. And here we have a data, because these are taking into account the safety issues. It was quite surprising, and it was a good message, in fact, based on the data from this study, that the safety signals were even lower, taking into account the prevalence in comparison to fast 3 trials and Odyssey outcomes and Fourier data. So it is a very good message for all those that might be a little bit afraid with the using of PCSK9 inhibitors. But when we look at the what the efficacy. As you might see, there was a significant reduction of the LDL cholesterol after 4 to 12 weeks, and there was a maintenance of the reduction by 30 months. Altogether, when we look at the number of patients being on the target, it was still the target below 70 because the study was designed in 2015, 2016. About 2/3 of those patients with FH was on the target of the therapy. So I believe it is a very encouraging data, taking into account the using of the triple therapy in patients with FH, because in these data, it was one of the reasons that this data was also very useful and very important. About 40 to 70% of those patients were treated with statins, ezetimibe, and PCSK9 inhibitors, and it was a difference in comparison, for example, to Fourier and Odyssey outcomes, when only 3 to 5% of patients were treated with ezetimibe. Okay, what about the registries with PCSK9 inhibitors of FH patients? Here you have a data from the British Columbia FH registry. And in this data, the investigators decided to compare those patients treated with and without PCSK9 inhibitors in patients with FH between 2015 and 2017. And they noticed that if they try to be optimal with the therapy without PCSK9 inhibitors, they might only reduce LDL cholesterol level by about 5% in comparison to those treated with PCSK9 inhibitors, because then they were able to reduce LDL cholesterol level by about 55%. The same results, in fact, were observed in the CARE-HI registry, FH registry in Germany, because as you might see, it was a very important registry because about 30% of patients were treated with PCSK9 inhibitors, FH patients. Quite surprising for me, it was the fact that a very low percentage of those patients were treated with rosuvastatin, which is completely different in comparison, for example, to Poland and other countries. It might be a great topic for discussion during our question and answers period. But as you might see, when we look at the number of patients being on the target below 170 and below 100, only patients in group 1 and 2, and those patients were treated with PCSK9 in monotherapy, in the combination therapy, were able to achieve LDL cholesterol level and to be on the target even in 3/4, 75%. So we have the comparison not only from randomized control trials, but also from the observational data from registries, that PCSK9 inhibitors and the triple therapy is very effective. That is why I believe that for FH patients, we shouldn't ever forget about the ezetimibe, because ezetimibe might be very useful in order to be on the target in the therapy. What is more, it is another confirmation of my words. These are data that were presented during American College of Cardiology virtual congress, which was at the end of the March. As you can see, only for those patients being with the triple therapy, so PCSK9 inhibitors, high dose of atorvastatin, rosuvastatin, and ezetimibe, most of those patients were able to achieve level of LDL cholesterol around the target, because it was the target, you know it very well, based on the recent European Society of Cardiology, European Atherosclerosis Society guidelines, should be at least below 70, because it is for the people from FH finally are those that should be treated as those with at least high or very high or extremely high cardiovascular risk. What is more, from the same data, we know it very well that only for those patients treated with PCSK9 inhibitors, in this situation it was alirocumab, the investigators were able to achieve level of LDL cholesterol below 55 in almost 95% of patients, and below 40, so 1 millimole per liter, in about 84%. So in fact, it is very similar to data which was presented and obtained in a VOPAX trial. You know very well, it was data for those patients treated with PCSK9 inhibitors during the hospitalization. And we know it very well that based on this data, again, we were able to achieve the level of LDL cholesterol below 70 in 95%, and over 90% the level of LDL cholesterol below 55. So we know it very well that for patients being under very high cardiovascular risk with baseline level of LDL cholesterol, which is also very high at the very beginning, with 200, 300, 400, it is triple therapy is very, very important, and we should do our best in order to be as low as possible for those patients. What is more, at the same Congress, we were first data of how effective might be the therapy with PCSK9 inhibitors in kids, in children with FH. And as you might see, treating of patients or children patients with FH might cause the reduction of the LDL cholesterol level by even 50%. These were data from phase 2 trial. And you know it very well that phase 3 trial is still ongoing. So we have been waiting for the final results from this data. But I believe we have another tool in order to be effective in the most severe FH children patients. What is more, we have also another data, despite the data from Tausig trial with evolocumab, that also from alirocumab in patients with homozygous FH patients, treating with PCSK9 inhibitors might reduce LDL cholesterol level by even 27%. Okay, what about other drugs that might be useful in patients with FH? You know it very well that when we use therapy every 1 per month, so every 2 weeks, it might be something a kind of phenomenon which is called visit-to-visit LDL variability. And we know it very well from different data, from sub-analysis, from cohort studies, that visit-to-visit LDL variability might be associated with the increased risk of the cardiovascular outcomes, including all-cause death, stroke, coronary event, and cardiovascular event. And that is why it was a kind of idea to create a drug which is based on the small interfering RNA targeted to PCSK9 inhibitor, PCSK9 protein, that might completely stop the synthesis of PCSK9 inhibitors and might cause catalytic degradation of PCSK9 microRNA. And that is why small interfering RNA, inclisiran, might be very useful in order to reduce PCSK9 and in the end reduce LDL cholesterol very effectively. And these are a kind of a program which was designed at the very beginning, which is called Orion. And as you might see, a part of this program is also dedicated to heterozygous FH and homozygous FH patients. And based on the very important data, we know very well that the most useful use of inclisiran is every initial dose and then the dose after 90 days, because altogether it might cause that these 2 doses might reduce LDL cholesterol level by even 50% after 9 months. And what is important, the response for this therapy is very, very good, because all patients responded for the therapy with the highest level of response, which was associated with the reduction of LDL cholesterol over 140 milligram per deciliter. So it was very, very effective. And we have obviously the first data that was presented during the ACC Virtual Congress. And as you can see, based on this presentation and based on this data, that this therapy, inclisiran, was associated with the reduction of the LDL cholesterol after 18 months by even 55%. And what is more, in 54 patients per 100, this therapy was associated with the availability to obtain the level of LDL cholesterol below 55. So it was a very, very effective therapy for very high-risk patients, including FH patients. And finally, we have also data for very important drug that might be used in patients with FH, as well as those that are not able to tolerate statins, because bempedoic acid is a pro-drug in muscle and mitochondrium, and this is a drug only in liver, and that is why there are no adverse effects in patients which are prone to be with statin intolerance after statin therapy. And what is more, this drug is very effective because based on the data from the phase 3 trials, it might reduce LDL cholesterol level by about 20-25%. And what is more, on the other data and analysis from the phase 3 trial, it was a pooled analysis, we know it very well that it might also reduce CRP protein. So it might be anti-inflammatory drug, which is a little bit similar to statins. So it is very important, because we know it very well that we are not effective in the reduction of the inflammation. We have statins, we have now bempedoic acid, but in fact we know that we are very limited in the use of methotrexate, canakinumab, and other drugs. So I believe that it is another chance in order to use an effective drug in the therapy of the patients with the increased level of CRP and inflammation. Thank you very much. Once again, I would like to kindly ask you to ask questions, because I can see we have a first 5 questions. I believe they are not easy, so please be very careful with those questions. But I believe that we start after the very important presentation by Professor Branislav Vohnout. Brano, we keep our fingers crossed for this very difficult presentation, because I wanted you, and I've asked you to present data how to be on the target with FH patients with the available therapies. So Brano, the floor is yours. Thank you very much.
Hey, Maciej, thank you very much for invitation, and of course, good afternoon to everybody. I think that almost everything was already covered with your presentation and even with the previous one. Anyway, let me try to respond to the difficult questions, whether we can effectively achieve that such a really huge reduction of LDL cholesterol in patients with familial hypercholesterolemia. So, okay, good. So good, my conflicts of interest. Well, I'm sure that this audience is pretty familiar with new risk categories that defined very high risk and high risk patients. Considering FH patients, as Michal Vrablík already mentioned, those patients with FH with atherosclerotic cardiovascular disease or with another major risk factors are considered or evaluated as a very high risk patients. Then those FH patients, in the absence of atherosclerotic cardiovascular disease or another major risk factor, are automatically considered as a high risk patients. Then what is really new in current, I'm so sorry because I'm just missing the button how to move. Okay, so what is new in the risk categories is so-called extreme risk category, where patients with atherosclerotic cardiovascular disease who experience a second vascular event within 2 years, it's not necessary that it was the same time as the first event, while taking maximally tolerated statin-based therapy. In those patients, we would like to reach LDL cholesterol goal less than 1 millimole per liter. And as I will show you later, probably this will be pretty difficult in FH patients. Sorry. So let me move. Good. Now, this slide has been already shown in previous presentations, and this is really nice example to understand clearly and easily why it is important to treat patients with FH. So we know that the cumulative LDL burden in FH patients is really long life. And based on whether we have homozygous or heterozygous FH patients, those patients, they have 20 years earlier, or even more in homozygous patients, they reach the threshold for the possible cardiovascular event. And what is even more important is that we know from observational studies that if we start to treat them early, even with lower doses of statins or later on with high doses of statins, then we can shift the real risk of cardiovascular disease almost at the same level as in non-FH patients. Okay, so let me move. Good. So what are treatment recommendations from current guidelines published in 2019? So in FH patients at very high risk of atherosclerotic cardiovascular disease, LDL goals are more or equal to 50% reduction of LDL cholesterol from baseline and LDL cholesterol target level less than 1.4 millimole per liter. And now I am talking also specifically about FH patients. And in the absence of atherosclerotic cardiovascular disease in FH patients or without another major risk factors, patients with FH are high risk and LDL goals are more than 50% reduction of baseline LDL levels and LDL level less than 1.08 millimoles per liter. For those patients in the extreme risk group, the LDL goal is less than 1.0 millimole per liter. Okay, move. Good. So what can we do, or what are current recommendations for the treatment of FH patients? So first of all, treatment should be started with high intensity statin therapy, and in most cases in combination with ezetimibe. Of course, this is pretty logical, as we know that baseline LDL levels in FH patients are high. So it really has no sense to start with lower doses of statin. Really, please start with high intensity statin, and in those with very high LDL, then you can start really in combination with ezetimibe. Then PCSK9 inhibitors are recommended in very high risk patients with FH if the treatment goals are not achieved on maximal tolerated statin plus ezetimibe. And again, considering the effect of the treatment with statins and ezetimibe, we can clearly understand that PCSK9 inhibitors should be used in a really important proportion of FH patients. So now, just a bit of mathematics. I think that this slide is quite good and practical, even for everyday work with patients. And here you can see that treatment with high-intensity statins can reach more or less around 50% LDL reduction in patients. If we add to the high-intensity statin also ezetimibe, we are more or less at the level of 65%. If we add in a triple therapy, so high-intensity statin plus ezetimibe plus PCSK9, optimally, we can reach 85% reduction of LDL cholesterol. Okay, let's move again. Good. Now, Maciej already presented some data on PCSK9 inhibitors in population that included also FH patients. In this slide, we have two studies that were focused exactly on FH patients, studies with using both available PCSK9 inhibitors, so Rutherford 2 and Odyssey FH1 and 2 outcomes. And if you look at the slide, you can see that in FH patients on a maximally tolerated dose of statins, and many of them also used dual therapy with ezetimibe. After adding alirocumab, there was a really nice reduction of LDL cholesterol, around almost 60% compared to those with placebo. Quite similar results in Odyssey FH1 and FH2 studies with evolocumab, where patients were in group with FH patients with addition of PCSK9 inhibitors, there was an additional decrease of LDL cholesterol around 50%. So what is quite important or interesting are the baseline LDL cholesterol levels in both studies. So in those studies, FH patients treated with high intensity statins, and around 80 or more than 80% of those patients were really treated with high intensity statins, and quite an important proportion of those patients were treated with double therapy, high intensity statin and ezetimibe. their baseline levels were around 3.9 millimoles per liter in the Rutherford trial, and in Odyssey FH1 and 2, the average LDL was 3.7, so far away from target levels that we wish to see with our FH patients. Then adding PCSK9 inhibitors, there was really substantial decrease of LDL cholesterol up to 0.5 and 0.8 millimoles per liter in a group on triple treatment. Now, well, we know that clinical trials are nice, but usually we use selected patients in the clinical trials. Those patients are, let's say, more controlled. The adherence to the treatment is much better than in real life. And Michal Vrablík already presented data from the study that was performed in Czech Republic and in Slovakia. And he showed us that in a real life, even that, as he mentioned, the data comes mainly from the pre-PCSK9 era, we can see that treatment of FH patients in a specialized lipid centers that are really involved in FH projects both in Slovakia and Czech Republic, despite of maximally tolerated high-intensity statin treatment or high-intensity statin treatment plus ezetimibe, we reach the target level. And again, just to remember that that time target levels were 1.8 or less than 1.8 for a very high risk group and less than 1.5 for FH patients in a primary prevention. The success of the treatment was not so, let's say, exciting, and we reach only between 6 to 17% based on the risk category of those reaching target levels of LDL cholesterol. We published in the same issue of atherosclerosis another small study from Slovakia, where data were quite similar. Those in a primary prevention with target levels less than 2.5, we were successful only in around 10% of FH patients, and in those in a secondary prevention, the level was even, or the number was even lower, so it was around 7%. That means that our patients, despite being treated in a specialized centers, still with a double therapy, ezetimibe or high-intensity statin and ezetimibe, we were not able to reach the target level. Of course, we can ask what's the reason of not reaching target levels. Of course, one reason is that lipid-lowering therapy has still some limits, and as I showed you that we can expect up to 85% LDL cholesterol reduction with a triple therapy, but considering very high baseline LDL cholesterol levels, even this huge decrease in LDL cholesterol in FH patients might not be sufficient. Then the other obstacle is, of course, adherence and compliance of our patients with treatment. And when we ask our FH patients about, or patients and physicians in our specialized centers about the reason of not reaching target LDL levels or not using high-intensity statin treatment, then I was really surprised that there's quite a high number of patients that don't wanted to follow treatment because of some common, let's say, fake news and information about statin treatment, about side effects. And I would say that this is a real problem in a real life, at least in Slovakia. The for example, statin movement is very, very strong, and we can see it with our patients that they really sometimes even refuse the treatment despite of very high cardiovascular risk. So let me move. So as a conclusion, of course, FH, we know that those patients are at very high risk, and of course those with 2 and more cardiovascular events are even at extremely high risk. The problem with FH patients is very high baseline LDL levels, and we are limited, of course, with adherence to the treatment, but we are limited also with the current lipid-lowering therapies that we can expect up to 85% reduction, but this still might not be enough. And again, just a bit of mathematics. So in theory, if we start with LDL, with the FH patient with LDL 5.0 millimole per liter, then in a very optimal fashion, we can reach 85% reduction of LDL, so up to 0.75 millimole per liter, which is fine. That we are reaching, or we can reach the target level. Starting with 6.0, we can reach 0.9, and with LDL 7.0, we can reach 1.05. On the other hand, again, as I showed you in the previous slides, even with studies with PCSK9 inhibitions in FH patients, I am afraid that in a quite important proportion of our patients with FH, even or despite of triple therapy, we will not reach the target levels. Okay, so thank you very much for your attention.
Thank you very much, Brano. It was a beautiful presentation, especially I love your last slide, because it is very similar to those I presented on one of mine, when I showed the possibilities of the reduction of the LDL cholesterol level and achieving of the targets, taking into account the baseline LDL cholesterol, especially in FH patients, when we might observe the LDL cholesterol baseline levels about 300, 400, 200, and so on. So it is very important. So, but we have a number of questions, and this is good, because you know it very well, we like it very much, and we would love to answer all the questions. So the first question I can see is probably to Ivan. It is dedicated to you. But obviously, I would like all of us to discuss and to say about our experience, and especially in the therapy of FH patients. So the first question is about what about triglycerides level in patients with FH? Whether it is important or not, whether we look at it or not, and what is your personal experience, Ivan? If I may ask you to try to answer this question.
Yes, of course. Well, the triglycerides are also important. By definition, FH patients don't have high triglycerides, but they can have high triglycerides because beside the disease, they have normal lifestyle. And our normal lifestyle is that we may be 35-40% of our inhabitants have metabolic syndrome. So triglycerides also can be elevated. And this is every single risk factor with an FH, with the genetics, just is adding up the risk level. So I think that the uncontrolled triglycerides are also a problem for the cardiovascular risk in patients with the FH. Of course, if those triglycerides are too high, if the patient is, for example, diabetic or consume alcohol, or they are above 12 millimoles per liter, there is a risk of acute pancreatitis, which is very, very often. And so I think that the triglycerides also are the problem.
Okay. But Michal, Brano, whether for you, if you can see that we have a patients with FH without genetic diagnosis, without phenotypic diagnosis, that we are sure that it might be familial hypercholesterolemia, and we have a high level of triglycerides, a high level, for example, of ApoB, do you also consider that it might be familial combined hyperlipidemia as a kind of differential diagnosis because it is something that I believe we sometimes forget, and it is very important to try to differentiate, right? Michal Vrablík, what is your experience in this?
So I was called first, so I'll start. Basically, we also, well, I totally agree with you. FCH is finally the most common inherited lipid disorder, though it's polygenic. So we don't see the clear traveling of the disorder in the pedigree as in dominant conditions. Secondly, we also need to think about another, though even much rarer condition, which is familial dysbeta-lipoproteinemia associated with ApoE2 homozygosity. And that's typically presented with pretty severe combined hyperlipidemia. And it's highly atherogenic because we know it's a remnant disease. So basically these people would have sky-high ApoB and their atherogenic, their lipid profile is highly atherogenic. But it's a different condition. But to tell frankly, the genetics has taught us a lesson. We do have, for example, FH confirmed homozygous patient with homozygosity for LDL confirmed LDL causal mutation, and her triglycerides are 10 times the upper limit of normal. So as Ivan has said, basically we may have a combination of basically a few dyslipidemias in one. FH plus a condition that increases triglycerides as well. So typically we see isolated hypercholesterolemia, but don't be surprised if you have a genetically confirmed heterozygous FH plus increased triglycerides.
Yeah. Brano, do you want to add something too?
Yeah, I agree. But I mean, practically speaking, well, let's say if you ask me the same questions about triglycerides and FH 25 years ago, you know, when I started in the field, that time increased triglycerides, there was strong suggestions to really consider the patients as a familial combined, which anyway should be treated, very high cardiovascular risk. Now, because of obesity, metabolic syndrome, as Stephen mentioned, of course, we can see more frequently those also patients with FH with higher triglycerides. But very practically, when I have to decide to whom to send to genetic testing, and at least in Slovakia, it's pretty expensive, then if I have a patient with higher triglycerides, then usually I exclude the patients from the genetic testing and I send the simple hypercholesterolemia patients just to save money, because at least my experience is that the positive genetic diagnosis in those with high triglycerides is much lower than in those with simple hypercholesterolemia. Of course, still you can expect. I remember a paper written by Marcel Arca years ago, where they identified something like 30% of FH positive or genetically confirmed patients among those originally considered being familial combined hyperlipoproteinemia. But usually, if triglycerides are pretty high, after excluding diabetes, whatever, then I have doubts whether the patient is FH.
I believe it is a very important comment. On the other hand, I'm a little bit jealous with you, Brano, because I didn't know that you started with FH, with treating of FH patients at the age of 5, because 25 years ago you were 5 only. So it is a good beginning. It was a good beginning indeed. Yes. On the other hand, we need probably to remember two things. That obviously it might happen that we will have patients with FH with severe hypertriglyceridemia. It might happen, right? I believe with Brano that it might be associated. We need to think that it might not be FH, having patients with severe hypertriglyceridemia. But on the other hand, we need to treat those patients, obviously, because it is very, very important. Okay, the second question is quite important, yes, because it is in FH. Target LDL levels are justified by compensating the lifelong high LDL levels. Do you think that in patients that tell us, I always had somewhat higher TC, we should apply the similar approach? On the other hand, what to do in order to convince our patients, including those with FH, to be compliant, adherent to the therapy. Ivan, Michal, because I believe that we have different experiences in order to be effective in the therapy with patients with FH. So, and not only with FH, but severe hypercholesterolemia as well. Ivan, let's start with you.
Unfortunately, yeah, thank you, Maciej. Unfortunately, as I said, I meet my FH patient after a major cardiovascular event, unfortunately. So it is not so hard to convince the patient that this is the thing that happened to him is not good, and it's for sure connected with LDL that is maybe native without therapy, 8 or 10 or 5. Or when you talk with a patient and he says, oh yeah, my grandfather died very young because of the myocardial infarction. My father is 60, he has 4 bypasses. And I am 30 and I had already myocardial infarction and smoke. So in this case, I don't have any problems in compliance. And I think the transfer with the patient is very essential.
Okay, so I believe these are very important words because in Poland, for example, the mean age of the diagnosis of FH patients is 52. So what to do
in Croatia?
What to do in order to be more effective?
The problem is the awareness. Yeah.
Yeah.
That means. Sorry, Maciej. Yeah, that means that those patients are recognized after a major cardiovascular event. That means that. In most of the cases, I think.
If I may add to that, my experience is you don't really have to wait for the event if you really properly follow the pedigrees, because it's, once again, autosomal dominant condition. Basically, somebody in the pedigree must be the carrier of the mutation. And if you search long enough, you always identify the relative that basically was the one from which the disease was inherited. So I would say the familial screening is the key. And this is the major advantage of classical FH compared to polygenic forms of hyperlipidemia, that it gives you opportunity to really work with families and you don't have to wait for the event. And I have a number of successful stories because we've been, basically, I have the pleasure of working in the oldest center for FH in the country that was founded in the 50s of the 20th century. So basically now, after 70 years of operation, we do have success stories because there are pedigrees where they understood the need to bring their children in for examination at the age of 5. And we had the opportunity to really treat the affected individuals lifelong. So now I do have individuals who are in their 80s, FH heterozygous patients, who for the last 35 years have been treated with statins. And these 35 years were enough to save their lives, to save them from premature vascular events. And their children are now 50 and they're free of atherosclerosis. If you really start statin early enough, you don't really achieve very low levels in all of them, but it's enough to bring them to, let's say, population level of LDL. And from a long-term perspective, if you treat really decades, it yields wonderful results. So familial, let's say, screening, familial work is crucial.
Yeah, I totally agree. 1 second, Ivan, if I may. Because, for example, in Poland, we have been thinking and we have been preparing now in order to have a universal screening of all children at the age of 6. It is a problem because in Poland we have almost 40 million people and about 12 million people, 12 million children. But altogether, I believe it is the only way in order to start with, to find the high LDL cholesterol level children and then to diagnose mother, father, grandfather, grandmother, and all the family, because in fact we take care of the whole families. And this is something that Michal mentioned, that then we have a population effect, because if we start early with the children, if we start to usually mother and father of a child at the age of 5-6 is about 38 years of age. So it is still early in order to start the optimal therapy. We might predict a number of cardiovascular events, and we simply have the healthier population. Ivan and Brano, please, at your experience, in fact.
Yeah, thank you, Maciej. I completely agree with both of you and with Michal. And I have a question for you, Maciej. It was unclear. This 50 years of age, were you thinking about index cases or whole population?
It is whole patients we have diagnosed in Poland, because in Poland we have about 4,000 patients diagnosed. And when we look at the mean age of all those patients diagnosed, we have about 52.78 age of patients. Obviously, I agree with you. Most of those patients were after acute coronary syndrome, unfortunately. But the good thing is that for last several years, I don't know whether it is the same situation in your countries, that we've noticed a large involvement of the interventional cardiologists, because for many years they were simply a little bit outside of the diagnosis of patients with FH. And now they realize that it might happen that if they have a patient with a very high level of LDL cholesterol at the admission to the hospital with ACS, and this patient is, for example, this patient is below 50, below 35 with acute coronary syndrome, this patient might have simply and usually have FH. And this is a great added value, because altogether we have a network of centers in Poland now. We are at the very beginning still, but we have a network of centers, including preventive cardiological centers, endocrinological centers, lipidological centers, and interventional cardiological centers. And that is why I do hope altogether we will be very successful in the next few years in the diagnosis of patients with FH, because we predict in Poland to have even 150,000 patients with FH. So it is a large number, and we diagnose less than 3% only. Brano.
Well, I absolutely agree with Michal, but of course, both we have grown on MedPed projects, so that the family approach is crucial. That's the most effective way how you can, using the index patient, how you can identify new family patient, knowing that 50% chance in a first degree relative. So I would say this is crucial. Then considering pediatric screening, in Slovakia, we have such a general, universal screening at the age of 11 and 17. The problem is that then there is no good, connection between pediatricians and, let's say, cardiologists or lipidologists that take care about adults. So in that sense, we still miss those patients, because even that they are followed by pediatricians, of course, as children, they are without any cardiovascular events, and there is nobody or just a few pediatricians sending us parents to our specialized centers. So universal pediatric screening is good, but it really requires a consequences of good network of lipid clinics. And anyway, I'm remembering in my mind one family that I have in my practice, that I know that the patients from the age of 5, when he was first time visiting our center, that time his father really refused the treatment with statins. Now they visited me after more than 20 years again, and of course the father already got 2 MIs, his brother with MI, but the young man, now he's around 30, he's treated with statins, and I really believe that he will be free of cardiovascular events in future.
Thank you for this comment. Ivan, you wanted to add something?
Just a short comment. The lacking of awareness. We had, I think Michal was also last year in Torino, where Professor Guardamagna organized the lipid school, pediatric lipid school. And the conclusion was, okay, we are not aware because we don't see the changes. But we see the changes, internists, after the patient has 18 plus years. So maybe this is also the point.
Yeah, thank you. I believe that a very good response and solution for this might be such a center I have, because I have a center for adult and children. And for example, in my center, we have a very strict collaboration between pediatricians and cardiologists for adults. And that is why we diagnose both FH in pediatric population as well as in the adults. And that is why such complicated high references center, I believe, is a kind of response in order to be effective. Okay, but we have a great question, I believe, very, very tricky one from Sergio Kaiser, we know well, and we say hello, welcome to Sergio. Any role of CAC testing in FH, like de-risking patients deciding whether or not adding PCSK9 inhibitors based on the population by Minama et al., where 49% of the 204 adult FH had 0 CAC score. What is your opinion about that? Okay, well, Michal.
Of course, subclinical atherosclerosis adds definitely the information. On the other hand, we know quite a lot about the cardiovascular risk in definite FH. So basically, I think that should I have a patient with a confirmed LDL receptor mutation and the diagnosis of FH, I know that his or her risk of vascular event is 5 times greater than in a non-FH individual with the same level of LDL cholesterol. Basically, it's high or very high. And the question is whether the calcium scoring adds something into the management of the patients. So basically, in other words, would I do something differently? Should the calcium score be 400 or should it be 100? I perhaps wouldn't. So but that's my opinion.
My opinion is almost the same, because I do believe that CAC score is very useful when we would like to add, when we would like to intensify the dose of therapy, especially in low to moderate patients. But when we have FH patients which are at least at the high cardiovascular risk with lifelong risk, I do not believe that CAC score might add something to our diagnosis therapy or something. That is why I believe that it is an issue of the further investigations, but I believe at this moment I wouldn't measure CAC score for my patients with FH. Okay, but let's look at another question, very important one. Thank you for the fantastic presentation. It is not a question, it is a great information for all my great friends and lecturers. From our colleagues, Peter Penson from Liverpool. Peter, hello. How should be best identifying the missing FH patients? Should we be screening lipids, or do we need more widespread genetic testing? We have just a little bit discussed about what to do in order to find our FH patients. I might add that, for example, in my hospitals, taking into account the data we have in our system, we usually analyze every 2 weeks the data from all the patients, from all the departments, in order to look whether we had patients with LDL cholesterol level over 190, because then we might find, for example, someone with the risk of FH. We obviously have a good communication with the general practitioners, and we have also patients from general practitioners. But what are your idea in order to not to miss FH patients, in order to be effective in the finding of these lacking, let's say, FH patients? Yes, Ivan, please.
So I have to admit that everything that I know about FH, and in the last 5, 6, 7, 8, or 10 years, I've learned from you guys. You have to be aware of that. And I upgraded this knowledge.
I love him.
Listening.
I love him.
Yeah. No, but to be honest, I'm honest. Actually, we have started one pilot project which involves every 5th citizen of Zagreb. There are 110 GPs. And through the IT, through the program, we developed, on one click, they can make the report which of their patients are FH. And so they have names. So every single GP has around maybe 8 FH patients. And then we have electron way to consult my lipid clinic. with the lab results, with the therapy, is if needed. So it was very, very efficient during the COVID infection because the patient couldn't go from one site to the other. And so this is the first thing that was the idea. It was a bit stopped because of the pandemic and everything, but we will continue. The second thing that we want to do is that Brano said to screen the children when go to the school. But Brano told me the story about their screening several years ago when the pediatricians were not aware. So we are thinking that we will also do the webinars, and I hope so, face-to-face meetings and congresses with the pediatricians and GPs just to increase the awareness.
Yeah. Okay. Yes, Michal, please. Mm-hmm.
If I may, I think children are crucial. We only need to really go to pediatric population and screen it. We've been running selective pediatric screening for 20 years, and it became totally ineffective. Mm-hmm. Because if you selectively say measure cholesterol only in those with positive family history of hypercholesterolemia or premature CVD, pediatricians wouldn't do it, unfortunately. So now we are trying to test similar approach as Maciej said, and you are starting, and colleagues in Slovakia have been already performing. That's universal pediatric screening. Simply every single child at the age of 5 would have the cholesterol levels measured. We are trying to implement point of care testing because simply we do have a wide network of established laboratory facilities. But if you give the requisition to a mother, asking her to bring the child to a lab next door, half of the people will not come. Yeah. So we are now trying to enhance the screening by point of care testing in pediatric offices so that nobody really can escape. But pediatric population is the key to me.
I remember the action on Twitter I started a few years ago, check LDL at least once in whole patients, because obviously pediatric population is the most important one. But for example, when I started to be the president of the largest obstetrician hospital in Poland, I've noticed that there is no recommendation in the world in order to measure LDL cholesterol during pregnancy. I was shocked because at the very beginning I thought that it is quite normal that during the pregnancy LDL cholesterol is measured. It is not. So that is why we started to do it, and it wasn't surprising that we found pregnant women patients with FH, with FCS, and so on. So that is why it is something that we should also discuss further, and I do believe that the ILEP recommendation that I do hope will be announced by the end of this year, because from my point of view, these are the most difficult ones. Lipid management in pregnant women, it is the most difficult recommendation we have been working on, but I do believe that we will be able to do it, because these are very important, because nobody looked at this idea for last 20-25 years. Okay, we have another very important question. In fact, we discussed it in one of our webinars in Poland about this, but I would like to know your opinion. What are the possible causes of lack of LDL reduction after PCSK9 treatment control after 3 months of therapy? Do you have such an experience that your patients do not have any effect on PCSK9 therapy? Ivan, yes, please.
It's a very funny situation, because our patient took the pencil and froze it. So he was keeping his drug deep frozen, so that ineffectively. And when we started, one of our patients forgotten to pull off the cap from the pencil. So, but we improved that, because we have now specialized nurse that just educated the patients with the PCSK9 inhibition. One of our patients, well, we do not do the genetics, but we did just for the experiment. And for example, he has ApoB genetic variation. So I was just wondering why is response such a not good in this case. So it was due to the ApoB variation. So
Brano, Michal, any experiences in this? Because I would like to say a few.
Actually, I have one lady, FH, without any cardiovascular event. She's FDB, so mutation in ApoB, and there is almost no or very, very low effect with alirocumab, but quite interestingly, she's not a responder even with statins and ezetimibe. So now she's on a triple therapy, and let's say adding PCSK9, or after adding, we decreased LDL by something like 0.5 millimoles per liter. Of course, one of the reasons might be compliance treatment. I would suggest as a first things to check whether the drugs are really used, whether maybe to really administer the injection at the lipid clinic. So that would be a strong suggestion. But in this lady, I'm sure that, or quite sure that she's taking treatment. I have no explanation till now. I mean, why?
Michal.
We had a few referrals even to examine the patients in the hospital during hospitalization for lack of response, and all the cases could have been explained by lack of adherence and frequently by misunderstanding that with the initiation of the injectable therapies, the background statin plus ezetimibe can be stopped. So sometimes simply the people understand that now I'm on injections and therefore I don't need to take my pills. So you see very little response, because if you miss the 50 or 60% LDL reduction induced by statin plus ezetimibe, PCSK9 inhibitor is not enough. So basically it's either non-adherence or stopping the background therapy. And apart from that, I got to admit, out of 300 individuals in our center, we have 3 with unexplained lack of response. So they exist, these people exist, but it's difficult really to explain.
But Michal, you need to take into account one thing, that if we have patients with statin intolerance, in fact, when we use PCSK9 inhibitors in monotherapy, we still might expect about 50 to 60% LDL reduction. That is why, in fact, the background statin with ezetimibe therapy is less important when we look about the lack of LDL reduction, which is usually defined as less than 30%.
Yeah, but Maciej, understand that basically if the patient is fully adherent to maximum dose of statin plus ezetimibe, he or she has 60% reduction from the baseline. If you add a PCSK9 inhibitor, you get another 50% reduction of the already reduced levels. So basically, and when you compare the, let's say, the final resulting levels of the triple combination to the situation when the patient was fully adherent, you still see only, let's say, 30% reduction, which is interpreted as lack of efficacy.
Okay. In Poland, we have few cases, and in fact, in the end, we do not know what is the reason of the lack of reduction, because we have been investigating it still, but we still believe that the most important reason is lack of adherence, of lack of understanding why this therapy should be continued. But on the other hand, in one case, we probably believe, because this patient is also have lack of experience of other cardiovascular drugs, so I believe it might be a kind of genetic predisposition of the lack of experience, of lack of efficacy of the other cardiovascular drugs. Okay, we have last 3 questions. 2 are quite easy, I believe, and the next we have a commentary from Sergio, which is quite important. One of them is from Mosen. Thank you for the presentation. Given recent years, we have an easy access to NMR data metabolomics. Wouldn't it be more practical and efficient to focus on the atherogenic lipoprotein particles, numbers, say ApoB, and diameter, rather than only low density LDL cholesterol to delay the premature mortality and morbidity? Do you think it is useful, and do you think it might be possible in everyday clinical practice? Because the biomarkers we use in everyday clinical practice might be very easy to measure and not usually cost effective, because cost effectiveness is very important for our patients. So Michal, Ivan, Brano, who would like to answer this? Because I believe the answer is very easy.
Yes, I would love to use NMR data for lipoprotein profiling, but unfortunately we don't have this option available at all. So we would have to send the samples abroad. And this is something I can't really use for everyday practice. Moreover, I'm not aware of a study that would show on a routine basis, because I think that nobody has ever tested that in a routine practice, that it really can add that much in the daily practice. But I'm strongly in favor of that in a research setting, definitely.
Yeah.
So it would be.
Yeah, because we are a little bit out of time, I believe that from the research point of view, it is very, very interesting. You agree with me? Because, for example, I have had an experience with NMR for subpopulation of LDL, HDL, cholesterol, and so on. So I believe it is a very, very important at all. But from the everyday clinical practice, I believe it is still not a time for new biomarkers, because the ones we have are completely enough in order to be effective in the prevention, therapy, and monitoring. Okay, we have two last questions. What is your opinion on the need to determine postprandial lipemia in patients with FH? Postprandial lipemia in patients with FH. What is your experience about it, and whether it is important or not for FH patients?
I think postprandial, the only thing that lowers much are TGs, triglycerides. Of course, the LDL variation is also important. We heard that on your last webinar. But I think that, well, because as I said earlier, if we have to reduce all risk factors when you have an FH, you should also reduce postprandial hypertriglyceridemia, for example.
If you agree with me, because I would like
you have to watch out for your triglycerides also.
Yeah, sure, obviously. Yeah. Okay, so I believe we agree that it is, I believe, less important in patients with FH, because we need to focus on LDL cholesterol, because it is the critical one in order to be effective and to be on target on the LDL cholesterol. And we have the last comment, I believe very important, Sergio. Michal Vrablík's comments are very important, and we all agree with this. Treating early can parallel genetic studies. 39 milligram per deciliter reduction in LDL cholesterol may lead to twice as much as RRR in events, and we know about it based on the CTT analysis. Sometimes the cause of high LDL persistence is very high lipoprotein(a). I have a patient whose LDL was with triple RX is 90, with triple drugs is 90 milligrams per deciliter, and lipoprotein(a) approaching 400. We know very well, based on the data from the last few years, that even in 30 to 40% of our patients with FH, we might expect elevated levels of lipoprotein(a). So I totally agree with Sergio that we might be on the target of the LDL cholesterol, and these patients still might be on the very high risk of the cardiovascular events due to lipoprotein(a). So what is your experience in the measurement of the lipoprotein(a), and in fact in the therapy of lipoprotein(a)? Because at the very beginning in my lecture I told you that only in 1 or 2 countries in Europe, it is for sure in Slovenia, there is a recommendation and the reimbursement for the application of the PCSK9 inhibitors in case of very high levels of lipoprotein(a). So what is your experience? Yes, Ivan, because we agree with Sergio.
Well, we are at the beginning with your story, with this story, and in 1 year in my hospital, we took all the patients that got acute coronary syndrome, ran them through the Dutch lipid criteria, and we pull out 50 patients. 35 out of them, so phenotypically FH, 35 was Lp(a) and 15 was FH. Lp(a) is not reimbursed by our national insurance company, but we treat those patients with PCSK9 inhibition because our hospital committee has to approve that. So I have to say what is the cost, what is the, so it is the medical indication upon the studies and everything. And then we treat those patients on the cost of, and we are in front of Atherosclerosis Society and the Cardiac Society, writing down the letters to our national insurance company, also to reimburse for the Lp(a), because from Zagreb to Slovenia is 40 kilometers, and in Slovenia is reimbursed, and in Zagreb is not.
I believe it is very important what you have said, Ivan, because in Poland we have two cases I consulted when there were patients with FH that they were unfortunately not treated with PCSK9 inhibitors, but they were almost at the level of the LDL cholesterol, because the level of the LDL cholesterol was less than 100, but they still symptomatic. They have recurrent cardiovascular events, and I suggested to measure lipoprotein little level. In first case, the Lp(a) was, as far as I remember, 194, and in the second level, over 300. And then I suggested to apply for the Ministry of Health for the urgent use of PCSK9 inhibitors for this individual situation. And there was an agreement in the end, so these patients were finally treated with PCSK9 inhibitors. But on the other hand, you know it very well that PCSK9 might reduce lipoprotein little by about 25-30% by maximum.
Only 30%.
So altogether, when we have 300, we were able to reduce lipoprotein little in one of those patients for about 117 altogether, but it was less. But it was, these patients was still at a very high risk of residual risk of cardiovascular events. Yes, please.
Many of
Brano, maybe Brano and Ivan, because Brano said that he would like to be the first, Ivan. You know.
Okay, yeah, no problem.
Yeah, I mean, I agree that or even I would recommend to measure Lp(a), even based on the guidelines, at least once in life in everybody. But on the other hand, the problem is that in different countries, as we already discussed, there are different prescription restrictions. So if I have no opportunity to treat the patient with PCSK9 based on those restrictions, then in that sense, probably, Lp(a) is fine to know, but what can I do? If I have no treatment, if I can't change my treatment approach.
Okay, because my organizers looking at me with large danger and anger. Sorry, because we are about 22 minutes after the time of the predicted and suggested time of the webinar. So if you allow me, I would like to kindly thank you, my great friends and lecturers, Michal, Ivan, and Brano. I would like to kindly thank all the participants and all very active participants that asked questions. In fact, we expected much more because we are here in order to help you in your everyday clinical practice. And finally, I would like to thank you, our partners, Amgen and Sanofi, that decided to help us in order to, and supported us in order to organize these webinars. On Tuesday, 13th of June, there is a next webinar, very critical one, because we will talk about the optimal management of lipid-lowering therapies in patients with after acute coronary syndrome, and we will also talk what to do in order to be effective with this therapy, in order to also to use PCSK9 inhibitors, and so on. And the last one will be on the 3rd of July, and it will be mostly dedicated to cases, so please feel invited to participate in all those webinars. Thank you very much. It was a beautiful evening. Michal, have a great vacations. We keep our fingers crossed in order to safely back to us. And I'm looking forward to seeing you all on the next webinars. Thank you very much and have a great evening. Thank you.
Thank you, Maciej.
Thank you,
guys.
Thank you, Maciej. Thank you, guys. Bye.
Yeah, good evening.